Hi, this is Dr. Mavin. Today we're going to be talking about acute coronary syndromes. Acute coronary syndrome is an umbrella term that encapsulates these three entities. The first is unstable angina, the second is non-ST elevation MI, and the third is ST elevation MI. You might be wondering, what does it mean to have unstable angina as opposed to stable angina? Well, stable angina is a type of pain that patients get when they have coronary artery disease that is usually exertional type of pain. It's a predictable type of pain, and it usually goes away within a few minutes. It's usually relieved pretty immediately with nitro. Whereas a whereas unstable angina is a different type of pain. It's a new type of pain. It's unrelenting type of pain, and it's oftentimes at rest. So we worry about unstable angina. Um, And the symptoms of acute coronary syndrome can be varied. The most classic is chest pain. Now, not every patient will complain of pain. They might call it discomfort, pressure, tightness, or fullness. But I consider it all a spectrum of pain. Now, some patients might not even complain of any symptoms within the chest per se. They might have pain in their arm, in their jaw, in their upper back, or in their upper abdomen. So it's very important, especially in diabetics and elderly patients, to recognize these anginal equivalents. And then associated symptoms can include shortness of breath and dizziness or lightheadedness. The two that I really worry about is nausea and sweating. When the patient's sweating, I'm sweating. I'm worried about ACS and particularly worried about STEMI. The risk factors for ACS include previous heart disease. If the patient's already had a heart attack, already has stents, then they have a big risk factor for coming in with acute coronary syndrome. The other risk factors include hypertension, smoking, diabetes, high cholesterol, and family history. A lot of these risk factors are modifiable, such as smoking, so it's important to counsel the patient to modify their risk factors for down the road. Obesity, sedentary life can also be a risk factor. A non modifiable risk factor is age. Usually, age above 45 is when we start to worry about acute coronary syndrome. Although I've seen acute coronary syndrome in patients as young as in their 20s. So it's important to get an EKG in even younger patients these days. This table goes over the differences, the EKG differences and troponin differences between the three. The symptoms in all three are very similar, so it's impossible to diagnose any of the three without actually getting an EKG and getting the cardiac biomarkers. So with the STEMI, by definition, there's going to be ST elevation. Um, in an NSTEMI, there's non-specific EKG changes. Oftentimes, it's a ischemic pattern like inverted T waves or ST depression. And with unstable angina, it could be a completely normal EKG, or you could have non-specific EKG changes. The troponin is elevated in STEMI and NSTEMI, whereas it's normal in unstable angina. And again, the symptoms can be very similar in all three. The underlying cause, what causes a STEMI versus NSTEMI? In a STEMI, the entire cross section of that coronary artery is occluded 100%. There's no blood getting through. With the NSTEMI, there's partial occlusion of the coronary artery. And with unstable angina, there's non-occlusive thrombus, but it's a little bit more than what the patient was used to. So that's why their pain is different, or it's new, or it's unrelenting. However, with unstable angina, there's actually no necrosis, there's no infarction. There's only infarction in NSTEMI and STEMI. And you can tell the infarction because when the heart infarcts, it releases the biomarkers or troponin. And with the NSTEMI, there's subendocardial infarction, whereas in a STEMI, there's transmural infarction. The treatment for all three are the initial treatment's the same. Everyone gets aspirin, everyone gets oxygen, everyone gets nitrates, everyone gets heparin. Whereas with the STEMI, after that, they go to cath lab. There's some other treatments, oftentimes that are done upstairs. Once they go upstairs, they'll get beta blockers and statins. Out of the treatments, the ones that are actually proven to reduce mortality are aspirin and beta blockers and revascularization, the cath lab. Whereas morphine, oxygen, they can be used, but I would go easy on both of them. They're not actually uh, evidence-based to reduce mortality. Here's a diagram of cross sections of coronary artery, the coronary arteries. On the left, there's unstable angina, so you'll see that there's increased thrombus compared to just the baseline plaque up top. And that causes no necrosis, but it causes the unstable angina pain, which is new, different, and at rest. In the middle, you'll see what an NSTEMI looks like cross-sectionally. There's partially occlusive thrombus, and that causes subendocardial damage. Whereas the STEMI, which is a true emergency, the patient needs to go to cath lab now, or at least within 90 minutes. That causes 100% occlusive thrombus. That artery is being strangled. There's no oxygen, there's no blood getting through. That wall is dying. There's transmural infarction. That patient needs to go now. So just go through some EKG basics. This is just a normal morphology of an EKG. There's the P wave, QRS complex, and then the T wave. And in between the QRS complex and T wave is the ST segment. This is normal right at the isoelectric line. And here's the STEMI. This is what we're looking out for, is if there's elevation of that ST segment. That is a STEMI. Although there are STEMI mimics, if the ST segment's elevated, doesn't mean the patient's having a STEMI. It could be pericarditis, it could be early repolarization, it could be a ventricular aneurysm. So there are some mimics that we need to be aware of before we just call the cath lab. We have to take the whole picture into context. With an NSTEMI, there can be ST depression, there can be T wave inversion, there could just be nonspecific changes. But remember, the troponin will be elevated in an NSTEMI. However, just like a STEMI has mimics with the ST elevation, an NSTEMI will have mimics with elevated troponin. So patients on dialysis oftentimes will have elevated troponin. Troponemia can happen from hypertensive crisis. Just age above 80 can cause baseline elevated troponin. And so it's important to recognize the other causes of elevated troponin and not just diagnose someone with an NSTEMI because of elevated troponin. So here's just a tracing of a STEMI. And this is in the pattern of an inferior MI. So you'll see elevation in leads 2, 3 AVF and reciprocal changes in leads 1 and AVLs. So what do you do when you get an EKG like this? This patient needs to go to cath lab now. That artery is occluded 100%. And time is muscle. So in summary, time is muscle. This patient, the STEMI, needs to go to cath lab now. And even if it's an NSTEMI, you need to start heparinizing them so that we can keep whatever blood flow open so that the clot doesn't get worse. It's important to get an EKG within 10 minutes of the patient's arrival. That's how we can differentiate between STEMI versus NSTEMI. And then the way to differentiate between NSTEMI and unstable angina is with the cardiac enzymes or biomarkers, the most sensitive being troponin. A STEMI has to go to cath lab within 90 minutes, and if there's no cath lab, then they get lytics within 30 minutes. All patients get oxygen, aspirin, nitro, morphine, that can be remembered with the abbreviation MONA, and patients will be started on heparin or low molecular weight heparin. Some patients will also get additional antiplatelet agents such as Plavix, depending on what the cardiologist recommends. And as far as the outcomes in the immediate setting, it's worse for a STEMI. That's in the short term, but long-term studies, a year out, 5 years out, the outcomes for mortality are very similar, and actually might even be slightly worse for NSTEMI because patients with NSTEMI, they oftentimes have worse comorbidities. They might be on dialysis, might be having brittle diabetes. So long-term NSTEMI can be just as serious as a STEMI. So when a patient comes in, It's very important to recognize acute coronary syndrome. And the heart is just such an amazing organ. It beats from the time when you're 5 weeks after conception all the way into till the end of your life. And when a patient comes in, it's very important to recognize acute coronary syndrome. Thank you. Bye.